Our speakers today, we have Wanda Penner, a nurse whose past experience includes working at Canadian Blood Services for 10 years in a variety of roles. She's also worked in the pharmaceutical industry for 4 years in plasma procurement as part of the Quality Assurance Department. Her current role as patient safety consultant at St. Boniface General Hospital for the past 4 years. She has remained interested in safe blood transfusion and participates as a member of St. Boniface General Hospital's site transfusion practice, as well as the Provincial Transfusion Nursing Resource Group. We also have Shelley Probizanski, who's currently a manager of quality patient safety and risk at Health Science Centre. Her role includes reviewing reported patient safety events and identifying potential areas for improvement. Shelley appreciates the impact of effective process improvement efforts and has a particular interest in blood samples.
Hi everyone. Welcome. Thank you very much for having us. As our title says, hello. Is it me you're looking for? A little bit catchy, right? Some of you recognize that. So I'm being a little tongue-in-cheek, right, about blood labeling, but it's serious business, and we're going to kind of go through today a little bit about best practice process. We're also going to talk about two sort of areas of breakdown that are quite common. We're also going to talk a little bit about how they're discovered. We're going to share some data, which is always important. We need to know where we've been and where we need to go. We're also going to share some real-time stories, so some actual events that have happened to our patients. Then we're also going to discuss the impact of those events. And lastly, we're going to just touch a little bit on what are we going to do about this. Then I'm going to turn it over to Wanda.
Well, we're here today because we understand that there is a risk, a lot of patients in our care having the wrong sample drawn and sent to the labs. Now this can be blood transfusion samples, but it can also include hematology or chemistry, that sort of thing. And we know there's both documented evidence of that happening, and there's also undocumented anecdotal evidence that that's happening on a regular basis. So we're here to talk about that because we know that the implications are very, very serious harm to our patients. As you can well imagine, if we are having the wrong patient blood in a tube, it can have a serious impact. What we're actually supposed to be doing is sort of what I'm going to start with, which is we have a practice, best practice that was based on the Manitoba Transfusion Medicine Best Practice Manual. That was developed, my understanding is that was developed with CBS and DSM and clinical nurses from all areas of the region, the various provincial regions. So this tells us sort of what's supposed to be done when a nurse or anybody who's going to go draw up blood on a patient is how they're supposed to verify that patient's identification. So the practice is that you're supposed to be asking the patient to tell you their first and their last name, and there's supposed to be a secondary identifier, such as your FIN or some other identifier if there is no FIN number, FIN being the provincial personal health information number. We know that that doesn't always happen, right? We don't always do that. So that is what's supposed to be happening. In the event that a patient can't give a verbal ID, then there's supposed to be 2 clinical staff members that are verifying the ID of that patient. The second part of the process is the actual labeling itself. So we verified the ID by having the patient mention their name, verifying the FIN number, and we're comparing that to their ID band in the hospital. When it comes to the actual specimens themselves, those specimens are to be labeled in the patient's presence. So we know we don't want them labeled before the event. We want them labeled at the time in the patient's presence. We want that label to include their name and their FIN number and the date of the collection. And we want that label to actually be attached in the presence of the patient in their room. There's also a requisition involved in the process, of course, and that requisition is also finalized in the room with the verifying the correct ID information is on that requisition as well. So the final check for whoever is drawing this sample is supposed to be that they verify that the sample, the patient's armband, and the requisition all match before they leave the room. An additional sort of step is that the College of American Pathologists require that we have an initial and date on the requisition and on the tube itself. So the tube itself needs to be initialed and dated as well. So that's accreditation body for both CBS and DSM, and that's become a criteria for how we label our specimens in the hospital.
So that's the process. So now I'm going to talk a little bit about the why. So why is it that there are gaps in that process? Why do events reach the patient? Why do we end up with wrong blood in the tube? So looking here, errors are more common with frontline clinical staff. So why is that? Interruption is one of them. Human factors, distractions, fatigue. So really the safest kind of work that we can think about is when it's uninterrupted, it's calm, you've got focus. That doesn't always happen, right? So when I don't have to tell you, but when you're a nurse working on the front line, you've got probably about another 20 things going on in the back of your head. When you have a phlebotomist who is steer towards that as their focus, to draw the blood, to purely come in, do that. That is their task. That is their only task. It's very hard for a frontline staff to make that their only task in their day. Again, no excuses, but these are the reasons why sometimes these processes don't work. But that's not the only reason. There's also appears to be two scenarios that keep popping up time and time again when we examine these events. So we're going to go through those two scenarios, and I want you to think about your own practice, how many times you might have slid into this, or you might have dabbled in this, or you might have done this. So scenario one, a pre-labeled specimen tube comes into the room with you, and unfortunately it has somebody else's information on it. The unlabeled tube, the information is not reconciled with the patient at the bedside. So where did this come from? How could that ever happen? What we learned is that in some areas, efficiency. We have a drive to be efficient. So then we start thinking about our processes to make them more efficient. And hey, wouldn't it be great if we were to prepare our blood tubes ahead of time and put them in a bag with the requisition for the person who's going to draw the blood? Wouldn't that save them time? So it's an error happens when that step occurs. You have the wrong label on the wrong tube, you go to the wrong patient, and you miss that final step of reconciling what is on that tube with the actual armband. Slide away from it. We miss it because we're so certain that what we have in our hand is what we intended to use. So that's one scenario. Another one is that you walk into an area to draw blood from a patient and there's no label on that tube, so it's a completely empty tube. So there you are, you draw your blood and you realize, oh shoot, I don't have the requisition, I don't have any labels. Okay, I'm going to go back to the main desk and I'm going to label off of a requisition. And guess the requisition made for somebody else. You thought in your brain, because your brain can only take in 9 items of information before a 10th one comes in and it pops out the other side. But you're quite certain that that's where you were heading. You label that tube with the requisition information. Don't go back to the bedside and make sure that that's what's on the armband, and we miss that step. So those are kind of the two scenarios when you think about process. Again, we've got to remove ourselves sometimes from the individual, and we need to think about the processes that we're actually working in, that we've created to be efficient.
Great. So how do we discover our mislabeling errors? Now, we've already talked about that there is some evidence out there, there's some data out there, a lot of it is anecdotal as well, but we know that it gets detected at various levels in the process. So sometimes it's on the unit itself. So somebody on the unit has drawn a sample and realizes afterwards that they messed up, that they had some sort of issue. It might be that they've compared the tube to the requisition and recognized that that mistake happened before that was actually sent off to the lab. It may be that somebody just became aware that they were drawing two at the same time and they're not clear whether or not they mixed them up. So those are the ways that the unit can detect them. And those events typically then they would be probably initiating some sort of occurrence report. We don't know that. It doesn't always happen, but they often do initiate an occurrence report at the clinical level. They try to fix it at that level. It never gets to the lab or to CBS. But we know also that many of these are detected at the lab when they actually receive the requisition and the specimen, and they discover that something doesn't jive. The requisition is labeled with one patient's information, the tube might be labeled with another's information, or it's just not quite clear to them. So they may detect that and get in touch with the unit and ask that that be corrected at the time. So that's another way. We know that these are being discovered. Probably the majority of them that are being discovered that really have the wrong blood in the tube are the ones that are being detected at Canadian Blood Services. That's where they often test and they recognize that the blood group that they've just tested doesn't match what the patient had on file before. So that's a very obvious sort of way that we can detect that there's something wrong with this picture. So this patient had a blood group on file before, now they've suddenly got a different blood group. There's evidence too that shows that there is a lot of these that actually go completely undetected because the majority of our patients in Canada right now, at least around 40% are O's, around 40% are A's, and with that happening, basically there's a risk that even if you're detecting, or if you're drawing blood from the wrong patient, you will still probably have 40% chance of actually giving them the right blood just by fluke because they actually might have the same blood type. So you might have an intended patient of an O, you might have had the wrong patient of an O as well, and then they end up being compatible and it's okay. So we don't know how many of those are happening. We just know that there is some of that occurring as well. So I wanted to just share with you the data that Shelley and I looked at our own data in our own organization. So Shelley works here at St. B, here at HSC. I work here back at St. B. And we both took a look at the occurrence data for our incidence of these events. Our occurrence data is very imperfect in this regard. It's not easy to glean this information. We don't have data points that actually that clearly sort of stipulate whether it's a mislabeling error or not. So we took a look. We found that HSC had 45 occurrences and 13 near misses. At St. B, I only found 18 occurrences and 0 near misses. Now this is again very imperfect for a number of reasons. One is that this is voluntary reporting, so we don't know that we're hearing about all of them anyway. And then again, what I already mentioned is that the data itself is imperfect because there's just not really great data points. We know that there are many more events than what we're seeing on our data. We know that DSM also does their own collection of data when incidents occur. However, DSM also has a bit of a difficult time drilling into whether or not this is a mislabeling error only. So we've heard from them that they also have a difficult time getting very accurate data on this. Because there are so many organizations involved, there's no sort of one central place where all this data is stored. We don't find that we can sort of have one repository of the occurrences that happen on the clinical side and then the lab side and then CBS. By far, the most accurate data probably comes from CBS because they are the ones that do discover these events, as I already mentioned. And they're the ones that actually know how many samples they're getting where the wrong blood has been in the tube. So this was either an event where the intended patient's blood was identified with another patient's identification, or wrong patient's blood with the intended patient's ID. Those are the common scenarios. And they're looked at much more closely at CBS than anywhere else, being highly regulated, and also the importance of the significance of an error is the reason that they do a very in-depth investigation. So you'll see that there are some urban and rural data points here. I want to just thank Deborah Lane, who's here today. Thanks so much. Dr. Lane provided us these slides from CBS to show the data from there, so that's really great. We really appreciate it. What it shows is that there's both urban and rural incidences across the province, and we know that by far the majority, we've already mentioned, happen from clinical staff at the front line, and you'll see that in Dr. Lane's data there as well. The phlebotomist is most often a nurse in these cases. Dr. Lane was kind enough to provide us data for the last 3 years, so 2013, and there's evidence here that we had 2014, our numbers dropped a little bit. In 2014, we only had 6 data points. Again, by far the majority of them being nurses were in the urban setting in 2014, which is interesting. We had some in the rural setting at 2013, but 2014 it ended up being only urban settings. You'll also notice that there's a trend where it's often, if the unit is identified, it's either the ED or L&D, which is really, really common. Those are the 2 areas where these samples are being drawn in a big hurry, often in an emergency situation, and that's when a lot of the times we don't have the times. 2015, what struck me on this slide when I got it was that there's just really an increase. We're seeing an increase in mislabeling errors as opposed to a decrease, which is kind of concerning. We seem to not have, even though we know at our level, for instance, at the clinical level, whenever there's an occurrence and we know about it, we do some coaching with our staff, we tell them it's happened, we follow up with them. But for whatever reason, we're still seeing a lot of this, and in fact, it's on the rise in these, at least here in this province. So again, you'll see that by far the majority are nurses. There's even a physician on this slide, and most of these, again, are urban L&D or AD situations. Especially concerning on this slide because there's actually only 9 months on this slide. We don't even have the full year, and we've already got more data or almost as much data as the other 2 years put together.
Thanks, Wanda. So data is important. It's important for us to see where we're coming from, where we're going. It's important to note the trends, and it's important to think about, okay, we need to figure this out. What I'm going to show to you or share with you in the next little bit is actual real occurrences that have happened to real people like yourself and our patients. I always tell people that an event isn't just the patient. An event is typically 2 people or more because there's healthcare providers involved as well. So we're going to go through. So the first one is that blood work was drawn on a patient in bed 10. So here's one bed. The blood work is drawn. The unlabeled tube was handed to a unit clerk and is told, this is for bed 10. The unit clerk then proceeds to stamp up a label or make a label for the blood work, and it's labeled with bed 5's addressograph. Error is noted when the nurse of bed 5 then receives those blood work results and says, well, hold on a minute, there is no blood work ordered for bed 5. Why am I getting these results? And it's discovered. and then the blood work has to be redrawn on bed 10. Fortunately, this was caught. There was no critical values. Nobody acted on the values, but these kinds of things do occur. So there's a process break there. There's a step in the correct way to label blood, to take a sample that we missed, results in this event. So this is one that has happened not that long ago. Again, this is also another near miss, is what you would call this. So CBS received a type and screen sample for a patient, we will call her Jane Smith. The sample was O positive. Fortunately, their previous record stated that Jane Smith was A positive. This is where we're very fortunate that we have records on individuals who have already had a type and screen, so we can catch these. CBS contacted the ward, and it was confirmed that the blood sample had been taken from another patient and mistakenly stamped with Jane Smith's information. And again, had there not been a previous blood group on file, this person could have received a fatal transfusion. And again, it's not just that person that received the fatal transfusion, the person administering the blood as well. Occurrence number 3. This is a postpartum patient who required an urgent type and screen for an emergent OR. So you can imagine the urgency, the pressure, the gotta get it done. We talk about efficiency. We talk about the pressures of pushing us sometimes past our capabilities, we think, to follow a process. An unlabeled tube was used, so the step to verify the label to the patient's armband was not done. So in other words, they had an unlabeled tube, they drew the blood, they carried it away. Another nurse assisted with the labeling and sending the specimen due to the urgency. The wrong addressograph was used to label that sample, so they walked away, they went over to the desk and they used the wrong one. Incident was discovered by the unit before anything actually reached, and they contacted the blood bank and said, we have made a mistake, we've caught it. Fourth one. So this one was an actual event that reached the patient. So this was a verbal request for a group and match on a transfusion, called them patient A. So in other words, they actually required a transfusion of blood. So it was a verbal request. The phlebotomist proceeded to a multi-patient room, and they ended up locating a patient that they were told patient A was in, patient A was in the third chair. So they went to the third chair. It actually was patient B. So what they did is they drew the group and match, or what we would call a type and screen now, and they brought that to the main desk for labeling from the requisition. So they left that multi-patient room with an unlabeled tube. They went to the desk and they filled it out from the requisition. The requisition was actually for patient A because they required a type and screen for a transfusion. So that's what was done. It was sent away. The cross-matched blood arrived. Of course, it was checked just like you would, because now everything matches. All good. They administered it, and he had a post-transfusion reaction. So in the post-transfusion reaction protocol, you draw another sample of blood and you send it back. And sure enough, doesn't it come back as a completely different type and match? And that's when it was discovered that there had been an error. What was very, very lucky for this gentleman, because he received a portion of unmatched wrong group, is that he had quite a cocktail of antihistamines because he was receiving Remicade. And so he did not have a full-blown anaphylactic fatal reaction. He did require to stay in hospital for 32 hours, which was completely unexpected for him. He was a young man with a young family. So we put him out for 32 hours. He was scared because he wasn't sure that he was being monitored very closely. People were telling him, we think you're okay, but we need to check. Up until that time, this was quite a while ago, but you can see that we're now trending up. We're having a lot more near misses. We're lucky. Our patients are lucky. This fellow, he wasn't so lucky, but he was lucky in other ways.
So what is the impact to our patients? Well, we know there's several impacts that can occur as a result of a mislabeled sample. There's both safety impacts as well as inconvenience to the patient. Some of the inconveniences are that they may just simply need another type and screen drawn, cross-match drawn. That might be for some patients quite a process if they're really terrified of getting a needle, that type of thing. So for some patients, there's that type of inconvenience in that they have to have their sample drawn again. There might just be a delay in the blood transfusion, which may or may not be serious, right? The delay in blood transfusion is something that relies a lot on what's going on at the time. If it's an emergency scenario and we don't have a cross match, then probably there'll be an increased use of emergency blood. And that's a resource issue, right? We're using up emergency blood when we probably didn't need to, had we had the right sample drawn in the first place. Finally, though, obviously the most concerning of all is that the wrong blood type has the potential to really increase the morbidity or mortality for these patient populations. So you need to look at it from a perspective of, yeah, there's a lot of potential problems for that patient, but the worst of them is of course if they get the wrong blood type, and that's the last story that we just mentioned. A little bit of data from CBS. We know that we give wrong blood to 1 in 14,000 patients. That's 1 in 38,000 units. So we are giving it on a regular basis, relatively regular basis. 50% of those patients will have some sort of reaction, and 50% of them are going to be pretty lucky and not have anything happen. So that's, you know, that is obviously telling too. We might not know, we might not have even realized we did it if they didn't have any type of reaction. Fatalities are rare. We know that they're really, really rare, but there are fatalities as well, and it's 1 in 1,800,000 is what I read last. Again, we don't really know how many near misses there are that needs to be drawn, a new requisition that needs to be filled out, as well as they had potential problems here in terms of these incidents that are getting through the system without us actually identifying them at the time. And again, based on the processes that we're doing, we're not following the process because of whatever our constraints are, and there's a big, big risk to our patients. Beyond the risk to our patients, there's also considerable work for everybody involved, right? We know that when a mislabeled sample happens, it can be a big impact on the resources and the workload for the team that's caring for the patient. They may need to notify the physician, they may need to notify the lab, they may need to notify the OR, they may need to follow up with the staff involved and do some retraining. There's going to be a new specimen that needs to be drawn, a new requisition that needs to be filled out, as well as they have to document the event. We want to document all these events in our record, in our health records, so they need to be charting it in the chart, as well as filling out an occurrence report. So it ends up being a lot of work for the unit involved. Similarly, the blood bank, who I think is sometimes stuck in the middle of these incidents, they're the ones that have a lot of work too, because they might be dealing with both sides. DSM might be dealing with the unit and CBS and communicating back and forth the circumstances of the event. So there's a lot of work, additional work for the blood bank staff who already are really, really busy, as we know. There's additional work in reprocessing a new sample again. They might need to have to reaccession, repackage up a new sample, ship it to CBS, that sort of thing. And then they also need to document their rejected specimens. They need to initiate their own non-conformance report. So there's a lot of work involved for the blood bank as well when this happens. And finally, for CBS, there's a really large impact there. Dr. Lane told me that these incidents can sometimes take her a day or more of work, just getting through the whole incident, investigating it thoroughly, trying to figure out what's happened, and trying to figure out what's the safest step to take. So that's really, really significant amount of resources and time spent on this type of incident. There might be notification of the labs, there might be the medical director talking to various departments in the hospital, but they might also, like Dr. Lane writes us a letter every time it happens. She actually informs the clinical area by letter. There's work associated with the investigation itself, the investigation of the discrepant results in the lab, so there's a big amount of work for the cross-match team itself. They're also going to be reprocessing a new specimen, that sort of thing. And they also have to reject the specimen, possibly initiate their own nonconformance report. So there's a significant amount of work generated whenever we do a mislabeling error as well. And that's just something, obviously the patient safety risk is our biggest focus, but we also, from a lean perspective, and in healthcare nowadays, we really talk a lot from a lean perspective. Are we very efficient when we're mislabeling it? Obviously, it impacts us greatly in terms of our workload.
We've shared with you what best practice says. We've shared with you a couple of scenarios that lead us to not follow that practice, or how the events kind of occur. We've shared with you 4 real events. There's more, but those are sort of the 4 that were, most common. And so now we ask and think about solutions. So this slide is really all about that. First step is to review your process. In your particular area, what is your process, and does it match best practice? Does it? And if it doesn't, how are we going to make it match? What are we going to do? Do we need to work as an organization? Do we need to work as a program? Do we need to work as a unit? Is it a unit level issue? Right? Is it that, are we meeting the blood specimen shall be labeled in the patient's presence? Isolated patients, what do we do then? Have we asked ourselves these questions? Have we even explored this? Have we paid enough attention to this yet? So that's the question. That's what this slide is about. Is it time to review our processes and make them right?
It for us.